Well, welcome everybody. Thank you very much for joining us again for our second journal club sponsored by CST, the Canadian Society of Transplantation, on this 26th of April. We're very happy to get our second event going on. Our first event was in February, and I'm not sure if any of the people that are involved today were involved in that event, but it was a very successful event, and we're very happy and to try to gain kind of momentum in our second event here. So I thank you very much for participating. So I'm going to introduce our speaker, but just first want to welcome you from Winnipeg here. I'm hoping that you can see my slide of lovely Winnipeg in the spring. And first of all, just to kind of outlay some of our objectives, this is a slide I shared with our first presentation with regards to what we envision the next steps of our kind of journey here with this journal club. And really our objectives are to share knowledge, experience, education, and really to learn from each other. We're involved now in a very complicated rollout of a DCD program that many of the programs across Canada have already embarked on, and we're looking to learn from all the different programs across the nation. I think there's great knowledge out there that we need to share nationally, and I think to make our programs better. The format, I think, for these events, the last one was a guest speaker, and this one is also a guest speaker. We also envision roundtable discussions and a more kind of formal article discussion and review. We do an R stream nationally via the GoToWebinar app that we're using, which has been very successful so far. And all of these presentations will be available on the web versus the CST, the Canadian Society of Transplantation website, with the link that you can see on the bottom there. So without further ado, I don't want to take too much of your time, but I just want to introduce our speaker. Dr. Adrian Robertson is a colleague and friend here in Winnipeg, Manitoba. He's the medical director of the Manitoba Organ Donation and the Gift of Life program here in Manitoba. He's also been heavily involved in the Canadian donation group within the CST, and he's co-chaired the meeting leading to significant practice change in terms of guideline adaptation, the conversations at the end of life involving organ donation, and that's what he's going to speak about today. So without further ado, I'm going to give the mic to Adrian via this application. And take it away, Adrian.
Thank you, Owen. I just need to move this out of the way a little bit and get this going. Okay, so thank you very much, Owen, for that very kind introduction, and welcome to everybody that's listening. We're starting, as usual, from fairly humble beginnings. This is, as Owen mentioned, our second presentation, our second National Organ Donation Journal Club. Really, for the most part, no area in the country has enough critical mass to really sustain the kind of organic growth and discussion that I think we need to be having on a national stage, and that's really part of the vision behind this. So it's a delight to be participating in the second one. We're currently putting together a board of advisors that will help us generate topics and speakers from across the country and around the world, and Owen is going to be doing a tremendous amount of leadership for us with that. So today I'm going to be presenting on organ donation requesting, taking a look at time and space. So I collaborated with the Canadian Blood Services and Sam Shami on a wonderful project taking a look at effective requesting and conversations at the end of life involving organ donation and organ donation consent. And with that, we came out with sort of 12 broad recommendations. There's work from that and from the literature review that really is too sort of microscopic to make it into the broader recommendations, and so that's part of what we're going to be talking about today, and in particular focusing on the time and space of organ donation as it fascinates me. So I don't have any conflicts of interest. This slide always disappoints me a little bit. In fact, I'm grateful I don't have any conflicts of interest, but it also means I don't live a very exciting or complicated life. So our objectives today are, we're going to discuss timing of organ donation conversations. We're going to discuss the space for organ donation conversations. We're going to talk about the experience of the family, and throughout this we're going to knit how improving organ donation improves all our medical care. And I think this is one of the beautiful things about being involved with organ donation. When we do our jobs properly, we improve all organ donation and all medical care. So time, and by time I mean all the aspects of time, the broader aspect of time. So how do we time our conversations? How do we time the timing to request? We're going to discuss pre-mentioning. We're going to talk about non-therapeutic ventilation in regards to timing. We're going to talk about decoupling in terms of time and in terms of teams. And we're going to talk about the time to donation and the time to requesting from the time of a decision to approach for organ donation. And see how each of these, not so subtly and far more than I would have expected before I started going through the data, affects both our families' well-beings and the consent rate. So space, again, we're going to talk about space in a variety of ways, but really we're going to talk about the space in which the donor family or potential donor family exists, the space in which we request organ donation, the space that's available to them as their loved one is sick or potentially dying, and take a look at how that affects that family's well-being. I have some sort of challenging questions to ask you in terms of where we should be in 2016, and take a look at what we would want for ourselves or for our families if we had a family member that was dying in hospital and we were looking after our family in that setting. Family experience is an obvious key component to organ donation consent rates. To think about family experience and organ consent rate as a simple end to a means is to miss the point completely. What we're really talking about is the family experience, understanding it, understanding the trauma that the family goes through, and understanding the journey that family must go through from the time they hear the news all the way through to the time that they might have to consider a question like organ donation. And we need to understand that experience starts long before the tragedy of the day. It starts with the stories of other family members and other friends that people have heard as far back as childhood, or their own personal experiences with healthcare. And we need to think about and take responsibility for our own actions as we treat people in our systems, and ask ourselves, are we building trust for the future or are we destroying trust? There's a huge number of opportunities to show compassion and caring, and those opportunities start with the very first call to 911, again acknowledging those that have come before from past experience for that family. There are very often hundreds of care provider interactions and contacts between the 911 call and a potential donation consent discussion, and each of those has an opportunity to build trust, build caring, build that sense of belonging, or to cause alienation and mistrust. So where do we start? We need to start with the families, especially in the ICU setting. For a very long time, we focused primarily on needs of the patient, and I think in adult medicine much more so than in pediatric medicine. The duty is, of course, to the patient, and in medicine we've struggled with the concepts of patient-centered care and family-centered care. And these two sort of ideas or central pillars of thought sort of wrestle over our souls in terms of who we do what for and who we take care of. As our society becomes more and more individualistic, what you can share with families and how you can interact with families seems more and more limited. But as we become more isolated in our modern world, the more families as individuals seem to need our care. And so I really think we need to, further embrace family-centered care and think about the experience of families in our ICU with a loved one that's tragically hurt or injured or sick. And I also think that we need to think a little bit about organ donation and family well-being as, in a way, a surrogate measure. So I'm not saying that everybody that says no to organ donation is an unhealthy family. I think that there are distinctly families that are meant to say no, and for them, when they're saying no, they're in their healthiest place. But being as 85% of Canadian families, when surveyed, support organ donation, and our organ donation consent rates are considerably less than 85%, I think, and I suggest to you that that difference between the 85% rate that we see in surveys and the actual consent rate we see in practice really has to do with the lack of family well-being during the time of tragedy, and in some ways our failure to meet that family in their place of crisis and guide them through the process. So think about that family experience. The family is called to the hospital or come with their loved one, and the first thing that they're told is wait here. And from that point on, through the rest of the journey, they have issues with access to the patient and access to information. They're put into a waiting room, and in that waiting room they fight the great many mysteries of the ICU or emergency waiting room: boredom, miscommunication, fear, to mention but a few of the many emotions. Our families are psychologically traumatized. They very often lack sleep for reasons that we're all aware of. A lot of these tragedies happen late at night or in the early morning hours, very often interrupting people's initial sleep. And then after that, people struggle to sleep with all the emotional and psychological stress that goes on, day after day with the fight for life after that, and dealing with the terrible news. Some of our families have had to hop on planes and travel long distances, adding additional stress. And then there's all the stresses that I think we're not that great at thinking about. And that's the stress that modern people have in the rest of their worlds when they're suddenly ripped out of their day-to-day routine and suddenly are dealing with this emergency. So there's obviously the tragedy of the day. Many people still have work requirements. It's lovely when somebody's work just says, go away, don't worry about it, we'll take care of everything. But if you're the business owner and there's nobody to step up, if you have business commitments that only you can take care of, if you have small children or animals to look after, all of these add significantly to your responsibilities and commitments, and finding other people to do those things adds a lot of stress. Economic stress can certainly be there. There are a great many people that really can't afford to miss a day or two of work, never mind having both earners for a family not being able to work, plus the extra costs around being not at home if you've had to travel, that are not insignificant. And then we should also remember that while a great many of us live in significant cities in Canada, there's a great many Canadians that live in rural and remote Canada, and for them coming to a major metropolis can be quite daunting. It can be very different from what they're used to, and if nothing else, even if they are used to the big city, they're far from their usual supports and comforts. So what do we do about it? The first thing is, I think we really need to acknowledge that our families matter and their experience matters. Families come first, or patients come first, but families matter. We need to get involved with our hospitals and get involved with our families' experience at our hospitals. We need to have clear systems of communication, systems that are clear to the family, that they know how to access information about their loved one, how to request a meeting, when they can expect more information, and where to get simple updates at any time. We need to have clear systems of access to the patient. Again, clear to the family. The family know when they can see their loved one next. They don't want to be in fear of missing an opportunity to see them or missing an opportunity to be updated. So we need to work on how we can reduce some of that anxiety and make things a little bit more predictable and clear. Communication. Communication is central to everything that we do, and as we know through college complaints and a great number of other venues, communication is without question one of our core competencies for building relationships, especially with families in distress. So families really need to know two things. The first thing that they need to know is what's going on and what you're going to do about it. But the second thing, which is maybe even more important, is that you care, and that you care about their loved one. There's an old saying that carries an awful lot of weight, and I think it's crucial that we understand it and embody it in all our work. Nobody cares what you know until they know that you care. And I think that that's just something that we have to recognize in all our interactions, that we need to actually care, number one, which means keeping ourselves psychologically healthy and away from burnout and overstress. And two, we need to be able to feel free to show that caring to the family so that that family can have more confidence in you, in what you know, and what you're doing for their loved one. Part of caring is having distinct and regular communication with the family. So every hospital across Canada is working on improving communications with families. There's a number of different ways to do this. The exact how doesn't matter, but I encourage people to get involved. The exact strategy isn't as important as that there's a clear strategy that's accessible and available to the family. Ensure that communication is designed to show compassion and caring. And again, get involved at your hospital. Now, when I say communication is designed to show compassion and caring, I mean that it's not just about meeting with the family. It's about understanding where the family is coming from and speaking to them in the state that they're in. For those of you that have heard Marcel Pincent speak, and he was our speaker in the previous lecture, and I'd encourage you to go back and watch his lecture. He speaks a great deal about reading the family and interacting with them in a place that they're in. Those are the sorts of things that communicate caring and compassion, using words that show caring and compassion, which many of us shy away from in trying to sound clinical. Unfortunately, that avoidance of caring and compassionate language takes away from the family's experience of that. So attending to the needs of our families, they need help navigating the experience of having a loved one in ICU. Our families need help coping and need help being okay with the helplessness and grief that they feel. Always seems strange to me that we have crisis counselors for a high school when something bad happens to a child at that school, and that we have limited resources for our families in the ICU. For sure we have social work, and for sure we have spiritual care, but it just seems to me to be out of balance with what we see happening in the social scene. And so I think it's incumbent on the rest of us, and I think it's humanizing and character building for us to do a lot of that work with our families, helping them cope and helping them navigate the system and the stresses. So now we're going to move on to space. So being a little bit cheeky here, your loved one is sick, you are missing work, everyone is supportive, but projects aren't moving forward and bills still need to be paid. You have to get a second job to pay for the parking at the hospital, and then there's the horrors of the ICU waiting room. Now the parking may not be that bad and many people may not have to deal with it, but the horrors of the ICU waiting room are very real, and they're all there. And I don't think I need to describe it to anybody that's listening. We've all looked into that ICU waiting room, and we've all wished that we never have to be there. Most ICUs have a family room or a meeting room or some other type of room that we can use at some discretion for families. Very few of us have that use of that room protocolized. And my question to you guys is, and the question to all of medicine in sort of 2016, is should we have a different space for families facing the death of a loved one? Should we have a space that they can be in by themselves, where they can go through the process without being in the public eye of everyone else? If the answer to that was yes, what would that space look like? What should be in that space? And how would we use that space? Now, we are talking about organ donation in the end as well, so here's a couple of quotes just from some papers around organ donation. Jacobi in 2005 confirmed that privacy was critical to organ donation decisions, and that without it, consent rarely happened. West and Burr in 2002 confirmed that a quiet room and a comfortable space for meeting increased consent rates. So if they increase consent rates, what else do they do for family well-being? And again, not wanting to do things just for donors, but really to drive better care in all our hospitals. The questions about what makes things better for organ donation are probably what makes things better for the care of our families in all clinical settings, regardless of the potential for donation. So what would the space look like that you would want to use if your family member was sick and dying in ICU? Would you want privacy where you as a family alone could meet, could discuss, could make decisions, could mourn together, could hold each other, to cry? Would you want access to a phone where you could call loved ones that couldn't come or haven't come yet, to that friend that supports you through all the thick and thin? Access to internet to be able to reach out into the World Wide Web for social media, Dr. Google, and I say that one with a little bit of chest pain. And finally, email. Who are you keeping in the loop? Who else is there to support you in the many different ways that we have support nowadays? Space. If we had such a space that families who had a loved one that was dying could use, those families would feel more valued, they would feel more cared about, they would have a better experience, and the evidence from the literature is that they are more likely to consent to organ donation. Now moving over to time, and it really is all about timing. When it comes to conversations and donation, it really is all about timing, and we mean timing in so many ways here. Getting that timing right means understanding the family's needs, understanding the family story, and being truly engaged in the experience of the family, which I think involves not only yourself being interested in the experience of the family, but the rest of your colleagues and the rest of your staff, and sharing the journey of the family with the team in terms of how we can enrich that experience for the family through the process. So timing discussions. There's a lot to talk about around time. The first is the simple concept of truth dumping versus stage disclosure, which is really about giving information at a rate that it can be absorbed. So I give you the following example. A young man has been in a car accident. He has a closed head injury with diffuse axonal injury, punctate lesions, and early cerebral edema. It is the neurosurgeon's opinion that he is unlikely to survive. Based on your clinical experience, you believe the same. You're going to meet with his mother. You have several choices. Choice number one is you can go in there and you can introduce yourself and be very kind and very loving, and you can say that your son has had a closed head injury with punctate lesions, with early cerebral edema, a GCS of 5, and diffuse axonal injury, and you and the neurosurgeon don't think he's going to survive, but that you think you should admit him. So if you were to give the truth that way, it may in fact be true, but it's an awful lot, and it's not very understandable. In a staged disclosure, you would give the same information, but not necessarily all at one time. So at the first meeting with the mother, you would tell her that her son was involved in an accident, during which time he suffered a severe brain injury. You're admitting him to hospital. You're going to do further neurological assessments. You're going to confirm with the radiologist what the CT results say, and have further discussion with the neurosurgeon and get back to them, all of which are true. Several hours later, you come back, having had more experience seeing the patient, seeing that their Glasgow-Coma scale is staying the same or worsening, not getting better despite therapy, that the radiology report does in fact confirm what you thought you saw, and you have touch base with the neurosurgeon. You now come back into the room and you relay to the family that the CT scan what was in fact confirmed as being that the radiologist confirmed your suspicion that the CT scan showed evidence of severe brain injury and that there was swelling in the brain. And then you use information that conveys caring and conveys something to the family that they can take to others. And so in the first conversation you said he had a severe brain injury. That's something they can share with the family. And now you're going to say to the family, the brain injury, with this confirmation and with him not responding, not having an improving GCS, I'm getting concerned that he may not survive, or I'm getting worried that he may not survive. When you say things like, I am concerned or I am worried, not only does that give the family something that they can tell other family members, but it also imparts that you care, that you're worried about the patient, and it's that language of caring which can contribute to the improved level of trust and connection between you and the family members. So you end up at the same place, but in terms of conversation and in terms of all the information, you just get there a little bit at a time, and you gauge it based on the absorption that the family can take all at one time. And you do this through understanding that it takes time with you for the family to learn to trust you and your team, and it takes time for the family to process and comes to terms with what they're hearing and what they're experiencing. So it's in no way meant to fool or to trick or to in any way corrupt the family's experience or your integrity. It's really about giving information slowly over time in bite-sized pieces that can be easily understood, as opposed to essentially vomiting up the truth and then saying, look, I did everything I was supposed to do. Now, pre-mentioning. Taking a look at the literature in terms of when is the best timing to request organs is, if nothing else, confusing. There are some studies that actually show that asking about organ donation prior to determining death can actually be superior in some settings. There's a significant number of studies that show that pre-mentioning and poorly timed pre-mentioning can significantly reduce consent rates. So I just want to break up pre-mentioning into the idea that a proper approach could be done prior to death, a proper approach could be done at the time of death, and a proper approach could be done after death. But pre-mentioning is not a proper approach. Pre-mentioning is really an unauthorized member of the team requesting organ donation. So and really what we want is we want to have somebody who is approaching a family to do it at the right time, in the right manner, with the right training, and not just sort of anybody anywhere. So the anybody anywhere really is the pre-mentioning, and biggest and most significant problem with pre-mentioning is that for many families it erodes trusts. It introduces the idea that you're more interested in organs than in supporting their family member, and when the family really isn't ready for that yet, it can basically destroy both their trust of you looking after them being alive and destroy any chance of organ donation, which really I think is a small thing compared to the tragedy that befalls the family that doesn't believe or trust in their care providers. Now, one of the challenges in all of this really is, what do we do with the patient that you think right at hello can't survive, and should you go on with non-therapeutic ventilation and delay discussions around organ donation? And you'll see how this kind of ties in more when I talk about time from admission to time to request, and how there can seem like there's an advantage to delaying conversations around organ donation. I don't think that anybody should be suggesting, and I'm certainly not, that we do non-therapeutic ventilation or provide care that we know is non-beneficial without disclosing that. I think that if you really do have somebody that you know isn't going to survive, I think it's fair to disclose that and then move on with whatever discussions are appropriate. I think we can always temper that, though, with the discussions at the right pace that the family can absorb and work with you with. A lot of this is made a lot easier in the era of DCD, but it's still a challenging question about how we have those discussions, especially when we're compressing time. So, juxtaposed with the idea of pre-mentioning as pre-warning, and again, this is all about timing. So if you pre-warn a family that their loved one is likely to die, or that their family member is likely to have the opportunity to be an organ donor, what does that do to consent rates? Now, this is very different from pre-mentioning in that it has to be done as in a way that's systematized. It's not posed as a question. You can't answer yes or no to it. It's simply a pre-warning. And what we've seen, and I'll give you an example from my own practice, what we've seen is that pre-warning, if done properly, can significantly increase organ donation, or also called forewarning. And there's 3 papers on the slide. There are Rodriguez-Viller 2012 paper and the Laura-Siminoff 2001 and 2010 papers that talk about forewarning leading to greater consent rates. So I just recently had a family speak to me about the shock of being thrown into an organ donation conversation, and talking about how they felt slapped by the sudden discussion around organ donation. This idea of being slapped or punched in the chest as a descriptor of sudden discussion on organ donation that the family couldn't have predicted or didn't see coming is not unusual, and it's described in the literature several times. The example I'd like to tell you about is when I was practicing in Thunder Bay, we had a unique sort of geographic isolation problem in that potential organ donors from Thunder Bay had to wait an additional sort of 8 to 10 hours in some cases because we didn't have a lab capable of doing blood and tissue typing for organ donation. So we would have to wait to send blood down on Air Canada, and overnight there was an 8 to 10 hour period, depending on the day of the week, where there wasn't a flight to Toronto from Thunder Bay. And so what this prompted us to do was to take a look at how we could shorten the time from consent to organ donation, as we saw that was clearly a stress on our families. And so we started approaching them with a protocolized consent package where we asked for consent to take a single vial of blood and send it down to Toronto, where it would be stored and not processed, and until such time as the person either improved or anyway, the blood wouldn't be processed unless consent was given if the patient ever died and the family wished to consent. So this was done very carefully, and it was very carefully done to not pose a yes/no question. People that tried to answer a question that wasn't being asked were redirected that this really wasn't a question about organ donation. It was a question about permission to draw a vial of blood that was not intended for to help the patient currently, and families took that amazingly well. What was also unexpected was that we saw a distinct spike in our organ donation rates the following year. Now, we were doing a number of things, so I can't tell you it's all about pre-warning, but I can tell you that we went from sort of about 35 to 45% consent rate that year to 100% consent rate the following year. Now, after that year, things did drop off a bit again, but dropped off down to the like 70% consent rate, which is all a wonder. I wish I had that. I wish I had the problem of a 70% consent rate right now here in Manitoba. So pre-warning can be a terrific strategy. I'm not using it here yet, but I'm certainly considering how it could be used, and I'd be delighted in the question period if anybody is using forewarning in their system and how they did it, or if they have any thoughts on it. That would be terrific. Okay, early referral and pre-approach planning. So these come directly out of the recommendations from the collaborative around discussions with families at the end of life about organ donation. So early referral and pre-approach planning definitely increase the success of having a successful organ donation conversation that meets the family's needs. And I would include in that a successful conversation for me and my team is a family that's meant to say no, that says no, and feels supported and cared about during that process. So early referral should occur in all cases, and I'm not sure that we have early referral programs in place in every site in Canada, but if not, you should be working on one. So early referral should happen in potential NDD patients. Anytime you have a patient that you suspect is going to go on to brain death, you should be discussing organ donation with your OPO. And in cases of DCD, the best timing there is after the decision to approach a family regarding end-of-life sustaining therapy, but prior to actually meeting with them. So pre-approach planning, the timing here is just slightly different. So with the patient already ideally pre-screened by your OPO and determined to potentially be a donor, the pre-approach planning should happen after, in the case of NDD, after the NDD, but prior to meeting with the family, or it can happen concurrently with meeting with the family, depending on your time. And for DCD, it should happen after bilateral agreement on withdrawal. After that meeting where there's bilateral agreement with withdrawal, but prior to approach. So for each of these, you can see the timing is fairly close. So you really need your sort of pre-notification to have staff there so that they can participate in pre-approach planning in a timely manner and then engage the family in a timely manner. Okay, timing the request, and this is fantastic stuff here. So we want to talk about timing of the request, but we also want to talk about decoupling. So decoupling is when we separate things. We can separate things by teams. So the care team might break the news that the loved one is dead and then hand off to an organ donation coordinator or organ donation team that then requests about organs. And then there's decoupling in time. Do you do it at the same time, or do you do it at a time spaced apart? And I'll tell you, I've been struggling with the time piece a lot. When I worked in Ontario, we did them sort of simultaneously. The organ donation coordinator was introduced as an end-of-life specialist, sat in on the meeting with the intensivist. The intensivist broke the news of, say, brain death. made sure that brain death was clearly explained, make sure there weren't any other medical questions, because they weren't going to be asking. They were able to comment on organ donation or comment on the process of discussing organ donation, and then hand it over to the organ donation coordinator that would then take a look at, that would then meet with the family immediately. Here in Manitoba, we've been doing it about an hour or a little bit over an hour later, and that's been somewhat dissatisfying, and I'm trying to look at closening up the time. Taking a look at the literature, Block in 2005 showed that those that met with the coordinator when we're talking about decoupling sooner than 15 minutes after the notification that the family member was dead were more likely to be dissatisfied and less likely to consent. And those families that met with a coordinator greater than 15 minutes after receiving the news were more satisfied and more likely to consent. Brown and company in 2010 found that those families that you met with within an hour of breaking the news that their loved one had passed away, consent rate was as high as 61%. Those families that had to wait greater than 3 hours, consent dropped to 51%. Now, that's a 10% absolute difference, and for a 10% absolute difference, we can certainly be there and meet with families within an hour, and we can certainly make that our goal. So, questions for you guys to answer, in text and answer maybe during the question period is, how do you, if you decouple in terms of time, how long do you take, and how do you inform the family that they're going to have another conversation, and who do you tell them the conversation is going to be with? Some programs are distinctly staying away from calling the person an organ donation coordinator at that time, and are referring to them as either an end-of-life specialist or a nurse specialist. There's a number of titles being used. And if you do decouple, and if you do decouple as a team, how do you introduce but request at the same time, how are you introducing that person? And again, the question is, who are you introducing them as? So, time of day. So you wouldn't probably think that the time of day, the time of the request, makes any difference at all. And then you'd be shocked to find out that it makes a 20% absolute difference. So Ibadat in 2014 did a very elegant study basically breaking up the time of request into 4 6-hour periods. Between midnight and 6 a.m. was 45%. Between noon and midnight was essentially 68, 67%. That's essentially a 45 or a 20% absolute difference, or 22% absolute difference, just by paying attention to time of day. I think that more than time of day, this likely represents 2 things. One is the rested state of the family. I've been in organ donation situations where, something catastrophic happened at 3 o'clock in the morning, and at 1 a.m. the next night we're declaring the person dead and asking the family to come in. And how could they possibly be in a rested state at that time? The other thing is when you think about delaying, you never delay from noon to midnight. You will delay from midnight to 6 a.m. or you will delay from 6 a.m. to noon, whether it's more convenient time, getting rounds through, those sorts of things. And any delay, as it turns out, may correlate with improved success in organ donation. And we'll talk about that in just a second. So, time to admission to the time of request. So Vane, in 2001, did a very elegant study looking at pediatrics, taking a look at of those families that consented, how long had they been in hospital, and of the families that declined, how long had their family member been in hospital, and found that in the consenter group they had a longer, by over double, the number of hours in hospital, 15.5 hours, versus decliners of just 7 hours. And I think this highlights that it takes time for the families to embrace their psychological trauma, to get over the shock, to start to understand, to start taking a look around at who's treating them, and to start to feel that they can trust people. And I think that it not only does it speak about organ donation, but it also just speaks about the well-being of the family, and it speaks about the speed with which we want to move through things, and in our sort of ever-present bed crunch pressure way, how much of that speed is in the best interests of our families, how much of that speed is in the best interest of their psychological well-being. In terms of understanding psychological well-being and consent rates in the way I'm trying to connect the two, I think this would suggest that time compression hurts our families, and again, important, but secondarily, hurts our consent rate. So the timing of request. We need to be in tune with our families in choosing the right time to approach. And you know, I think we've talked about less than 15 minutes is worse than greater than 15 minutes, and less than an hour is better than greater than 3 hours, but we don't really have a really nice rule to say when we should approach. And it probably really is a little bit different for every family. Some families have specific rituals they want to do, or specific visitation they want to do with with their loved one. Others just kind of need to have a sense of moving. But getting that right for that particular family is critically important, and this involves, you know, being in tune with that family. There's some considerable evidence that shows that families that think the timing is bad or poorly done don't consent, and those families that that think the timing is good do consent. So in this Rodriguez 2006 paper, of families that consented, 68% of the time they thought the timing was good, and in families that didn't consent, about 18% of the time they thought the timing was poor. I'm not sure that we can say much about the families that thought the timing, the families that didn't consent that thought the timing was poor. I think we're going to have somewhere in that sort of 15 to 20% of families that are always going to find the timing inappropriate because they think the question's inappropriate. But I find that the 68% doesn't match the 80 to 85% that we'd expect, suggests that we've got lots of work to do there. We also need to pay attention to family structure. And families have decision makers, they have people that they lean on, they have people that they trust. In our sort of modern, you know, consent, autonomy, individualistic world, we have distinct pecking orders of who can consent, and we tend to think only about, is that person present? We tend sometimes to fail to realize, well, that person might be the person that legally signs, but that might not be the key decision maker for this family. And we need to be paying attention to that and making sure that those people are present, not only to get consent done properly, but also they act as a support and a guide to the family. So Frutos in 2002 took a look at families where the key decision maker was lacking, and found that in consenting families the key decision maker was only lacking 5.4% of the time. But in families that declined, the key decision maker was missing 28% of the time, and in families that were undecided, the key decision maker was missing almost 16% of the time. So we can see that families that have a set decision-making function that doesn't necessarily fit into our legal structure struggle when we don't pay attention to who the decision makers are and make sure that we time the discussion so that they can be present. Time of asking. So really we want to make sure that the requester has as much time as that family needs. Requesters should ideally have no other commitments during the time of request. They should be relieved of all their other duties, and there should be a system in place that when somebody's doing a request, they have their other duties taken care of for them. Families need to not feel pressured or rushed. If they feel they are pressured or rushed, they're much less likely to donate. And we need to be very attuned to the fact that that pressure can be communicated in many ways, including body language, sense of urgency, tone, cadence, looking at a watch or phone. Lots and lots of subconscious cues. So in summary, we've taken a look at sort of the time and space that we conduct conversations and the time and space in which we take care of our families in ICU, with special consideration to organ donation. But I think if this is just about organ donation, I think we're missing the point, and that any kind of care that we provide that improves organ donation, by definition, improves the care for all other patients. I've asked you to pay attention to the family's experience and how we can influence the experience of families through our systems. I've asked you to understand the stress and the trauma that the families are dealing with and think about how we can act as guides and navigators for that experience. That we make sure that the families receive adequate communication, that that communication shows caring, and that we're mindful of our choices in time and space. And I hope I've shown you successfully that by choosing our times correctly, we can dramatically influence both families' well-beings, but also our consent rates for organ donation. So that concludes my talk. I don't know if I went fast or slow. We'll find out soon. I'm going to hand back over to Owen Mooney, and if anyone has questions, you can type them into the chat box, and Owen will take us from there.
Adrian, thanks. Thanks very much. That was great. That really was. So I will open up this webinar to questions. You can see as you attend the ability to answer typing questions via the kind of the menu on the right-hand side. I'm going to just end with a couple of comments, and then I'll open up to questions, as I have many for myself actually. What we're doing here locally is a very interesting endeavor, and this kind of goes beyond the scope of even organ donation, but this was just published recently from our local kind of medical magazine about how we identify patients that are dying in the ICU. And I'm a clinical intensivist. I actually didn't introduce myself. I apologize. I'm a clinical intensivist and organ donor, physician coordinator, but this is one of the processes by which we identify families that are suffering, and this was a nursing-driven initiative, which I find fascinating. They identify this basically symbol for the end of life of care, and they identify patients that are dying, and patients and family by noting them with a cherry blossom. And some of our, this is in a tertiary care site, some of our community sites have gone on to do other aspects of end-of-life care and to include a complete kind of end-of-life basket, which is actually quite remarkable, and I'm very interested to see, and they're studying this, and to see what the results of that are. I just to end the kind of formal part of the talk before we get into Adrian's questions, is I'd really like to thank Holly and Rob from Canadian Society of Transplantation for their involvement, both on the technical side and administrative side of helping me get this organized. Obviously the Manitoba Gift of Life and program for sure, and obviously Adrian for your talk today. Thank you very much for spending so much time, and I think this is, we have such an important job. And it's great. These are great topics to discuss, and we look to your feedback, because I think as much of we focus on randomized control trials, I think this is a very personal part of medicine that we cannot be studied, and we will only get better via discussion. So I look forward to your feedback and your discussion. And I ended our inaugural talk with Kristen Miller. She's a friend of mine. She's a heart transplant recipient, and I just love this quote. So I'll leave that for you to read. and she's a wonderful woman and quite healthy now. But the fact that she was given life, and her donor was given the ability to donate, I think is kind of the focus of our work. So thank you very much, Adrian. I'll open it up for questions, which I can see here. Please, so type your questions on the right-hand side, and I'll start this off actually. And I have a number of kind of marks here. I love the fact about the discussion pace, the point that you made about that, and I find as an intensivist doing these end-of-life discussions that pace is something that I don't actually pay attention to. I walk into the room with saying, this is an end-of-life discussion. I need to tell the family that their loved one is dying in a certain amount of time, and I really don't pay attention to how much of that information is being transmitted, and I don't give that family the opportunity to absorb that. And it's if you look at it, like the longest conversation we ever have would be, maybe an hour, maybe 30 minutes, maybe an hour. Take organ donation out of it. I'm just talking about the end of life discussion, and I think this really relates to when do you introduce the topic of organ donation, and really this relates to the pace of the introduction of just you're dying. Can you comment on the pace and kind of the stage disclosure that you mentioned?
So I don't think there's any particular either rhythm or particular pace. I think the pace is going to be dictated by both the patient's condition and the family's sort of state of readiness to hear the information. In terms of sort of stage disclosure, where you're giving information over a period of time. Usually after you've had somebody in the ICU for a couple of days, any stage disclosure should be kind of over by then. By then, everybody should be, clearly caught up. I think that when we're doing sort of stage disclosure, it's really more about, the compression of information or decompressing information over the first sort of, few hours to 6 hours, as opposed to getting people caught up in the last hour or two. I think you can look at stage disclosure at the back end by giving families warnings. So, for example, one of my particular warnings that I give a family is when I'm planning to do an NDD assessment, I meet with the family prior to the NDD assessment and tell them what I'm about to go and do. And no matter what sort of state of denial a family's in prior to that, when they know that I'm going to go and see if their loved one is still alive or dead, especially if I've been sort of building up to this over time with regular and proper updates, that really hones that family so that they're prepared to have a conversation that includes the information your loved one has died when I come back into the room 20 minutes to half an hour later.
And you use that language, alive or dead.
Yes.
Which I think is, yeah, and I think that's very important. Okay, sorry to interrupt.
No, exactly. And Owen, I think, I applaud you for your honesty. I think that concepts like stage disclosure, or matching the pace of the family, or watching for family absorption of information. I think that's something that's not commonly talked about amongst physicians, and I probably wouldn't be aware of it or be talking about it or thinking about it if I wasn't involved in ethics and I wasn't involved in organ donation. It's my interest in organ donation that really spurs me to understand this more, and then shows me how much more I can be doing for my everyday patients by applying the exact same rules.
That's a very good point. So I'm going to ask a follow-up question here. And how do you reconcile a patient with a devastating neurological injury, both by mechanism of injury and radiology, and you have, as you mentioned in your talk, there's group discussion about, oh my God, the prognosis is so terrible. Nurses, doctors, respiratory therapists, all discuss without in the family's absence, and then as a physician, when you're left with dealing with this family, this need to tell them all of that at once. And you mentioned truth dumping, which I think is such a great term, because gets back to my previous point about stage disclosure, that you're giving the family so much information at the same time. So I guess my question is about, are you okay, like ethically, are we allowed to knowingly share information in small bits? Is that okay?
So I think it depends. So if you know, and I mean know that this patient is either dying or dead, and there's no gray zone, I think it's probably important that you share that. And I don't think that anybody is going to, say that withholding something material like your loved one is probably dead right now, or is minutes from dying, is not withholding something that most people would consider a trust-breaking event, that you withheld that knowledge. I think that, so in that case you probably do need to say more sooner. I think the majority of cases that we see, though, really aren't that straightforward and really aren't that clear. And I think that there's a lot that can come with a few hours of observation in the ICU, to have serial exams, confirm the diagnoses, get radiologies, actual opinion. Maybe it's actually have the neurosurgeon see the patient as opposed to house staff, and just kind of dot your I's and cross your T's. And I think that if that's the situation, I think you're on fairly safe ground, telling the truth but not necessarily jumping to your conclusions, which haven't really been confirmed yet. They're just your gut. And then as you go along, your suspicions are more formally recognized by your colleagues and by the failure to improve on clinical exam, and then you can disclose things more strongly. I think that can be perfectly reasonable. I think the key here is one, are you holding anything back that's really material at that moment? And then two, are you doing this out of compassion for the family and trying to disclose information at a pace that's appropriate for them, or are you up to something nefarious? And I think if the answer is that you're not withholding any significant truths, that you're disclosing the truth over time in a way that is healthy for the family, I think you're probably on pretty solid ground.
You're absolutely right. That's fantastic. Well, I really appreciate you answering my questions there. And it's I often ignore the absorption rate. I talk quickly. These end-of-life discussions happen in very tense circumstances, and this is something that I definitely have to pay more attention to. We're probably out of time. I haven't seen anybody log any questions yet. I'm going to give you my email on the screen there. Hopefully you can see owen.mooney@gmail.com. We will have, hopefully this is the first, or this is now second, of very many more events to come. So I'd like to thank Adrian, Rob, and Holly, and all the people at CST for hosting this event. And it'll be available on the website and for your viewing or your colleagues' viewing in the future. So please just keep your eye out for future emails to participate in these great events. So thank you, Adrian. I really appreciate it.
Thank you, Owen. Thank you, CST, and thank you for everybody that tuned in tonight for this talk. Hopefully we'll see a great number of considerably more exciting speakers than me over the next couple of years, and we'll really get going as a national journal club. Thank you very much.
Great. Thanks very much.